developing a thyroid swelling in the front of the neck, right side, right lobe. Since 1 month, there was no history suggestive of hypothyroidism or hyperthyroidism. He had no history of any weight loss or decrease in appetite. He presented to us with an ultrasound report, which reported as right thyroid lobe lesion, which was thyroid spore, and the FNAC, the FNA was suggestive of suspicious follicular neoplasm or a follicular variant of papillary thyroid carcinoma. We took up the patient for total thyroidectomy along with selective net dissection of the level 6 lymph nodes. Intraoperatively, we found firm right lobe of the thyroid along
So
with...
basically a case of papillary thyroid cancer. We assist using the triple assessment. What are the components of triple assessment? You can remove your mask.
So components are clinical examination, history and clinical examination, high resolution ultrasound, and ultrasound guided FNAC.
What do you do before you do ultrasound guided FNAC?
So we do the thyroid function tests of the patient.
Why do we do it?
To rule out hyperthyroidism. So.
Why should you rule out hyperthyroidism before FNAC?
So there are two reasons. Mostly the hyperthyroid patients don't present with cancers, and in the cancer patients, hyperthyroidism is seen in less than 2% of the patients. And
what was my question? Why do you need to know before you do FNAC?
And so if the patient is hyperthyroid, why we don't go for FNA? It can precipitate thyroid storm in the patient.
And also the false positives you may get due to atypia. So many times you've discussed it. So it was papillary thyroid cancer and we managed it by, we can record it now, no problem?
No.
Tell your name loudly.
Arindam Kalita.
Get closer, sister. Get closer, further closer. We had done a total thyroidectomy along with central neck dissection, which means level 6 neck dissection. And today's
First postoperative.
third postoperative or second postoperative? First postoperative. That's what I'm asking. So, patient voice is good. I'm just letting you know. But the voice should include not just hoarseness, also the timbre. So the pitch, everything should be okay. We had kept it drained because we had done bilateral surgery and also neck dissection. So otherwise we don't necessarily need it. We had used a collar incision. We went through the platysma, then we lifted up the superior flap up to the hard bone, inferior flap up to the clavicles, and then through the midline we went through the deep fascia to go once on the right side, then on the left side. We first identified the strap muscles and selectively sternothyroid I cut to get a better access to the superior pole. And you are taught that ansa cervicalis supplies at the lower part, so cut on the upper side. Although we can cut it wherever, but it's preferable on the upper side. That is to provide a better access. Although the supply is segmental. And what is the supply? What supplies the strap muscles?
So cervical plexus along with the hypoglossal nerve.
Ansa cervicalis is what supplies it, which is formed by ansa descendens hypoglossi, joined by the branches from the cervical plexus. So we preserve it. We do dissection on that side. Middle thyroid vein is looked for. Any vein that drains the thyroid and goes beyond carotid to open and duodenal jugular vein is taken as middle thyroid vein. So we can get one or maybe two. Clip it and dissect it. Superior pole is like you will see in some of my videos on surgery. And today is the first postoperative day. What else do we need to see on day one? He's mobile, active, moving around. He's a fit young man, talking well, happy, joyful. What do you do, Arindam?
I'm a businessman.
He's a businessman, a young boy, he's a businessman, good. And his good news is young age is a better predictor. The risk factors are reduced. Ages, MS, masses, they all include age as a factor. Cutoff is 55. Below 55 is good risk. Above 55 the risk is higher. And females get it more often, but when males get it, the risk is higher, cancer. But in his case, the other thing is nodes, which we look for. That's why we do central neck dissection. And what are the boundaries of central neck dissection?
The lateral boundaries are bilateral carotids, and the upper boundary is the hyoid bone, and the inferior boundary is the suprasternal notch.
Yeah, this is an old classification, vein to vein, hyoid bone to innominate vein, not the suprasternal notch. So that becomes 6A and 6B. So 7 is mediastinal nodes. So this is what is the classification. And we do central leg dissection in most of them. Electively, if it is a slightly larger tumor, more aggressive tumor, and was papillary. If you look at the specimen, you must have seen there is a hard nodule on the right side. But why do you do total thyroidectomy rather than hemithyroidectomy here?
So, if the lesion size is larger than 4 centimeter, if there is a suspicion of extrathyroidal extension, and if there is presence of lymph node metastasis, we'll go for bilateral thyroidectomy in a papillary thyroid cancer.
Bilateral thyroidectomy means total
Total,
thyroidectomy.
sorry, total thyroid.
So there is a risk stratification criteria, which is that answer is incomplete. Because papillary is a multicentric disease, so if you do total thyroidectomy, it is easier to follow it up with thyroglobulin and also to do radioactive iodine scan to know the dose of radioactive iodine. So total is superior to less than total for that. But in very, very low risk patients, very tiny microcarcinomas, ladies that are young, we can observe, we can do hemithyroidectomy also. But they need to have a very high, very good risk factors. But otherwise, in a male gender with a disease which is large, presence of nodes, and in general, total thyroidectomy is better because following it up with a tumor marker like thyroglobulin is easier because unless you remove the whole gland, you can't have thyroglobulin as a marker. And then you can do scan to assess for the residual disease and treat it with radioactive iodine. That's the other advantage. Do you have a question? बोल सकते हैं
अभी तो कुछ नहीं।
अभी कुछ नहीं. Sister, steam inhalation is being given.
Yes, sir.
Goggles are being given. Steam inhalation is required for the throat to clear up and voice to get better, and we are giving lozenges. We are withholding this patient from thyroxine. Can you give me the reason?
So, we are creating a thyroid hunger in the patient so that if
For the eventual scan,
thyroid scan.
we want to make sure that the TSH levels go up. The hunger that you're talking about is the TSH level that you refer to. So we want them to be as high as possible. And in 3 to 4 weeks, we are able to achieve that level. And when we get that level, it is possible to do the thyroid scan and at the same time do the therapy if you want to. Because if you have a patient with thyroxine supplemented, then you won't get that kind of a hunger in the gland. That is why we keep the patient completely away from thyroxine. But that will give some symptoms. Patient will feel lethargy, will put on weight. So there is a concept of giving recombinant. Recombinant what?
Recombinant thyroxine.
What does recombinant thyroxine do? It's a good answer.
It will mimic it will produce the effects. It will give the patient relief from the symptoms of hypothyroidism. So, simultaneously, it will cause a rise in the TSH
TSH, very good, excellent answer. So it allows you to achieve what you want for the scan. At the same time, it doesn't let the patient have symptoms. But the cost is a factor, so we may not need it. Generally, in 2 to 3 weeks, we are able to take up the patient for this. And we left a drain, I told you, there's hardly any drainage. We are probably going to remove it. It's always good to leave the drain. What did we do specially to make sure that the patient doesn't develop the laryngeal syndrome in the post-surgery? You must have heard, or a lot of people get taught that keep a venesection set next to the patient's bed. If there's a hematoma, you will release the sutures line and that will relieve the airway pressure. It manifests as stridor, so it's not the lymphedema, that's edema. That's a wrong thing to assume. That concept is wrong. It is a collection which leads to increase in the pressure inside, and that creates a laryngeal compartment syndrome, which it presses on the veins which are draining the laryngeal complexes. So the edema happens due to congestion of veins. So even if you release this, the stridor won't go. You need to intubate, and intubation becomes a challenge. So what do? We leave some of the strap muscles open at the bottom, and we don't close it completely. We leave the fascia open for collection, and if you really think the dead space is huge, you can leave a drain. Okay? Now, I think we'll be able to discharge this patient tomorrow. And why are we getting the calcium done after 48 hours? half-life. So if you do it today, you may get the wrong idea about calcium. The half-life of the calcium is how much?
48 hours.
So we need to do it tomorrow morning, first thing, and also get the PTH and everything else done. How did we identify the parathyroids? Last question of the superior laryngeal lung and recurrent laryngeal lung, both the sides. Their identification is shown in a lot of my videos. Parathyroids we identify by their location, color, change of color, sentinel pad of fat, and
The artery branches of
the branches from the inferior thyroid artery. So the key is to follow the inferior thyroid artery. It will take you to the recurrent laryngeal nerve as well as parathyroids. And the color is golden yellow, but I don't know what it looks like. Golden yellow is golden yellow, but when you get close to it, it tends to get congested, what we call as an angry parathyroid. So it is important to be very careful in preserving parathyroids. And recurrent laryngeal nerve is identified by following the inferior thyroid artery. Where the branches cross, the nerve crosses through the branches. This is the nerve, these are the branches, or under or superior, but this is the most common presentation. So if you follow the inferior thyroid artery, which is not a branch of external carotid artery, it's a branch of thyrocervical trunk. So it comes from under the carotids and then it goes on to supply the thyroid. Major supply is from inferior thyroid artery, but more importantly, it supplies the capsular branches which supply the parathyroids, which you must identify. Alright? And this is the classical case. You can take it forward from there, and central dissection is also being done. Okay, and we'll send you home tomorrow. You're flying, or how do you go to?
Flying.
You fit to even walk to Assam if you want. Or everything is good about you. Okay?